Good afternoon, everybody. Welcome to July office hours. I hope everybody's having a good day. We'll go through some agenda items today. And I also wanted to just let folks know that, as always, we'll be recording this session and it'll be up on our website in the near future. And if you have any questions along the way, feel free to chime into the chat or just, unmute and ask away. And we'll talk through whatever we need to. I just want to confirm folks can see the slide deck and also can hear me. Someone could
Yes,
just
we
let me
can
know.
see.
All right, great. Thank you. And the chat function as well. I'm just double checking. It was working earlier.
Yep.
Perfect. Thank you. All right, well, let's get started. So we're going to do our normal policy and procedure touch. Any updates around policies, some children's updates, quality management performance. Going to touch on that CFR reporting requirement again, since it is something that all, especially mental health providers, need to do. And then the patient characteristics survey, which will be coming, we'll touch on that as well. So those will be the themes today. Policy-wise, Jessica's on vacation, so I'm gonna take it. And then if Taylor or anybody else on the team wants to chime in along the way, feel free. We'll be touching on assignment and referrals, comprehensive assessment policy, our health home supervisor and caseload policy, ratios, and also interpreter services. So those will be this month's updates as far as that go. Sorry, I'm trying to let people in at the same time as talk until I can do more than one thing at once, right? So our first policy is a referral and assignments policy. This is just an annual update. There's no changes or edits to this policy, but we wanted to make a note that that is up on the website. And if folks had any questions around this policy in particular, please feel free to bring them up at this point. Nothing here. All right. Again, this is an annual update. If you have any questions along the way, please reach out. Our next one is our comprehensive assessment policy. This particular policy does have some update in it that I wanted folks to know, and this is in particular around folks that are the age of 21 or under. We have to have a copy of their last well visit on file and immunization record. So that's something new that we want to make sure folks are aware of. And then the other note along with this that's been updated in this policy, if that person's well visit has not occurred in the last 12 months, or immunizations are up to date, they have to have a corresponding goal and a plan of care to address the follow-up. So those are things that we want to make sure that folks are aware of that are now included in this policy. Outside of that, it's an annual update as indicated, and there's no other changes. Anybody have any questions around this particular policy or anything they wanted to mention? All right. Again, this one, they're all up on the website as well, so folks can reference that if they need to. Our next policy update was around the supervisor and caseload ratios. An annual update again. We did do one change to this policy just for folks to be aware of, and we included the data den piece into the policy. So to help improve on the quality component as we keep looking at our quality program, we have that caseload ratio track within the platform. And this just noted in the policy that this is a tool that supervisors can use to assist in tracking caseloads when they're looking at that within their organization and supporting staff or decision making as far as filling positions or posting positions. So that is now included in the policy as well. Any questions or thoughts or comments around the caseload ratio policy? All right, we'll keep on moving. Next one is our interpreter services policy. So we had a couple of things here we just wanted to know. I mean, this policy has no major changes to it, but we want to make sure that folks know that, if the primary language is not English for a person that we have within our program, we want to make sure that number one, that person has an opportunity to be supported through an organization of choice, and those choices are provided for folks. So we do have agencies throughout our network that are bilingual as far as staff goes, and have the ability to support folks who may not speak English if it's another language. So we always want to encourage folks to reach out to the health home if you identify a person you're working with that may not speak English, and then we can, number one, work with you and that person to see, number one, are they open to a choice with another provider? If so, we would work to make that warm handoff. If not, they want to stay with you as an organization, but you don't have that capacity within your agency for bilingual. We want to still afford the opportunity for you to support that person through the interpreter services policy, through our language link virtual option, where we have multiple different languages that a person can have as an interpreter. So what we want to be able to do is be aware, number one, that that person has that need, and secondly, be a support as a lead through this policy, through the language link to get that person linked up. So we'd want to be in the loop on that as a lead health home. We are providing that service. There is a cost to it. We're more than happy to support that service and cost, but we do want to have that awareness so that we can be involved in those discussions. So those are the major points we wanted to just put out there with this update that we have with this policy. Um, Generally, we know before a person's assigned to an organization as a lead, if there is a language outside of English that that person is in need of for support. So that can be caught on the front end and worked with that individual in the organizations. But in the instances that is found out after the fact, which does happen occasionally, we just want to make sure that there's a cohesive track to make sure that person gets what they needs and that choice is involved as much as possible. So I don't know if there's any questions around this particular policy or thoughts, comments, etc. We were excited we had Language Link as an option. Even though it has a cost tied to it, it's something that allows us to open our ability to provide supports to people from all different backgrounds and language um, capabilities that they have that may be limited. When you working in a predominantly English area. Okay. All right. Well, that'll conclude the policy updates.
I just have a question, Travis.
Yes.
So as far as the cost is concerned, who picks that cost up?
The lead picks the costs up.
Okay,
So that's why we would want to be involved in that discussion. So it is a cost that's paid for through AHI. Like anything, if it's not monitored,
right.
it can add up very quickly. So we just want to have an awareness and look at options for people. And if as a last resort, there's not options and Language Link is the option that is decided, we'd want to have an awareness of that.
Okay. All right. Thank you.
Yeah. Any other questions or thoughts? Okay. Uh, so this IRM's notification, I know Jessica Robertson had sent out some information to the children's supervisors as this has been coming out. There's been, you'll see the memo attached here that was sent out to those supervisors as well. I just wanted to do another reminder. There's a 7/31/23 deadline to get this compliance tracker qualification, its training and IRMs updated and current. So that's a matter of ensuring that your point person for this for IRAMs for your organization is aware, and that's being worked on. Through AHI, our internal CMA, we actually have our human resource director involved, working with our supervisor through the children's side to work on getting this updated. And it really came down to ensuring that the HCS ID for each individual and their date of birth was inputted into the system manually if it wasn't something that carried over when the Department of Health did that upload. And in our instance, through our internal CMA, it was not carried over. So there's a manual effort going to input that staff's information, and then ensuring that the proper trainings are being tracked. So that 70-31 day is coming. It's not too far off. We just want to make sure that folks are on it. And the questions that folks might have outside of what I've just shared and what this memorandum has are to be sent to this bh.transition@health.ny.gov, and they can assist with any technical components that are pertaining to this particular training component. So just want to make sure folks are aware. Again, it's something with a deadline, and if you're running into issue, please reach out to this link and get that remedied. Any
Travis,
questions around this particular item?
yes, Travis, this is Raquel,
Hello.
over at Glens House. Hi. So I had reached out to Jessica because when we went into the IRAMs, all of our staff are in there, and we have adult staff that do have they have the potential to have an 18 to 21-year-old. So I reached out to Jessica to find out if they needed all of those trainings as well. And she said that they needed the mandated reporter training and the background checks completed, which I believe the background checks for all of our staff here they would have been grandfathered into that. But I just don't know when we go into IRAMs, they're asking for all of those trainings for everyone. So do we just leave them blank for the adults? I don't know.
Yeah, so we'll have to follow up on that. Jessica's out, so we'll have to do some follow up on that, Raquel.
Okay, I did leave her some messages, so I just figured I'd throw it out there. I'll be
Yeah,
patient.
I mean, if it's a person that's on the adult side as a care manager, I mean, the training requirement's not as specific as as a children's care manager. So that mandated reporter and background check would be the required piece for someone that's under 21, 18 to 21. As far as those other training components, we'll have to validate that though. So I'll
Okay,
work with our internal team and we'll see if we can get that answer for you sooner than later. Did you
okay, great.
happen to reach out to this link
I
provided?
didn't. I
Okay.
did leave Jessica a voicemail, two voicemails, and then realized she was out. So I can reach out to that and see
Okay,
if
and
you
then
want me
we'll try and do some digging around as well. So if you wanted to do the link, and then
to.
I'll
Okay,
talk internally with our lead group, and we'll get that. See if we can get a hold of a person outside of an email link, and see if we can get that answer quicker than later.
great.
So
Thank you. I appreciate it.
yeah, no problem. Anything else around this? All right. Just want to check the chat quick here. I see a yes. Hi all. Yes. Okay, that was just someone responding. Trying to multitask again here. All right, so moving on. The redesignation process. I touched on this a little bit over the last month or two. That's one of the things that through this whole budget realignment and the 30 million going into fiscal year 24, there's been a big look at the redesignation audit process and tool and some other things that we'll look at here in a moment. But I just wanted to bring into, for transparency purposes, what the state has come back with their redesignation tool. And this is effective August of this year, so it's going to come into play shortly for any redesignation that a lead health home goes through moving forward as of this August. So as I mentioned last month, I believe, we had a 2-year redesignation as an adult program and a 3-year as a children's when we last went through this. So we're actually coming due this coming spring, late winter, early spring for our adult redesignation, and then technically the following late winter, early spring for the children's. But what they've done in the past is they've kind of put the two together at once when they've done their reviews. I'm not sure if they're going to do that again or not this time, but at any rate, we're at least going to have the adult visit at some point, probably spring to mid next year. And a good thing about that is we know what this tool is now because it's out now and it gives us time to really thoroughly look at that. And I just wanted to go over for everybody for transparency just how it's broken out and what the Department of Health and OMH and OASAS and some of the other programs that come in as an audit team to audit the health home, what they're looking at. And the first thing they do is this domain one, up toward the top, under contents. It's an administrative review. So we do a self review of our own program. And that means our policies that we do, do we feel that as a lead health home, they're in line with what the state's put out? Are we putting them out timely and in the same timeline that the state puts out? Are we defining process improvements? Are there, how is that stuff being communicated? What are our validity behind, ensuring that these resources are getting out to the network, et cetera? So it's really a quality analysis and doing a self-evaluation. So that gets looked at. And then what happens is once we submit that, the state goes and they cross-check everything that we said we're doing to try and, do a check off whether or not, yes, it's happening or it's not, or it's partially happening. And this has to happen to bring it up to standard. Another part of domain one that's new now that wasn't part of it before is the home and community-based services for children. So there's going to be a score that's built in for reviews factored into that in domain one. So that's new. So what does that look like yet? We're not sure. So that's that first phase, the domain one. Domain two is looking at all of our different measurements that we're responsible through quality measures, process measures, measures that gaps in care that the Department of Health tracks for us, which is usually antiquated data that's 2-3 years old, but we're graded on it regardless. It's been a big bone of contention for a lot of leads in the state because you're getting scored on things that happened 2 years prior, 3 years prior, and you can't do anything about it because it's after the fact. So that's something that we're working as leads with the state to try and get altered a little bit. But basically, our performance measurements that we're upheld to as a lead for our region are scored. So that goes into our review. And then chart analysis. So that's doing a sample of all the different organizations in our network. And the state gives us a list of names basically that they poll. It's supposed to be random. And they take that percentage that they poll and they do chart audits. And then that's where you'll get like Jessica or I or Taylor asking certain questions and asking for follow-up if some of you have had that interaction in the past. That's because the state is asking for those items during the actual audit review. If we can produce them immediately, a lot of times that's a good thing. It doesn't go against our scoring. If we can't, then that's a check next to what's not there. And then there's a care management agency survey that happens. So the network gets polled. The supervisors get polled on how's the health home doing? How are we communicating? Are we responsive? Do we have mechanisms so we can be reached out to and get a response? Do we, communicate information effectively, et cetera? How are our relationships with the organizations? So it gives you as providers in our network an ability to grade us on how our performance is going. So then that gets factored in. And then all that gets scored and weighted. So it's a pretty involved, review. It's usually at least a week. Sometimes it extends past that, depending on what's going on in the review and if there's further questions. But that's generally the breakdown. So how does that all look? Well, when you get done with the review, they give you a score, how you performed. So to the left here, you'll see, and this just came out in the last week from DOH. So this is all current information. How was everything weighted? So ultimately, you're going to get a score in the old system on the top left-hand side of either if you did so poorly, you had 34% overall in all those domains, and lower, there's going to be immediate action that they would take. What's that mean? Probably not a good thing, right? 35 to 64%, you get a 6-month provisional designation. So that's a problem. You got to do a lot of work to try and bring that up. And then you'll see the level 3, level 3, 1 year, level 4, 2 years, and then level 4 again, 3 years. It looks like that might have been a typo. But anyways, the new key down on the left-hand side on the bottom, now you'll see if you go from the bottom up under that section, there's a de-designation component now. So that policy is still being finalized, But if a lead health home with all those domains collectively scored through their formula is below 69%, you're de-designated. So that means you lose your designation as a health home, lead in the region, which can lead to other actions being taken. If you're a 70 to 79%, your 6-month provisional, and in a year, that year category changed and the 2-year changed. So in the past, the old scoring method, you could see above, if you had an 80%, you got a 2-year designation. Well, that's not the case anymore. You got to have an 85% to an 89 to get a 2-year designation. So they did like a 5% swing, which is going to make it difficult for some health homes out there, depending on where they scored in certain areas. And then you have your 3-year, and then now there's a new category. So there's a de-designation category now, which is new, which is not good. And then there's a 4-year designation, which is a new category, which is superb. So that's where those changes happen. The weighting in the middle, before I get into that, I don't know if anybody had any thoughts or questions. If you find it's beneficial that I'm even going through this, I hope you are. If not, tell me, then I'll stop and we'll move on to the next slide. But just wanted to make sure that we have that out there so you understand why we ask for certain things, why we have certain policies in place. Weighting. So the weighting is broken out. So domain 1, you can see how those sections are scored: 30% for 1, 20 for 2, 50 for 3, which will equal 100%. And then how do those sections individually broken out? So you can see domain section 2, there's certain percentages based on certain things they're looking at in those sections. If you look in the domain 3 section at the bottom in the middle, if you see in the middle of that chart, service chart and plan of care, those two components are 50% of that 100% score in that section. That gets back to that chart audit. So that's why that's so important, and that's why, we're done so much work in our quality program in our region in the last year and a half to get things in place policy-wise, but to also provide tools to the network, such as the data den, the quality notebook, the step process for corrective action, so that we can help support you all in doing your work, but also provide you the tools so that you can effectively do the work without having to go to 50 different places to try and get the information you need. With the ultimate reason to ensure that quality and compliance is occurring for the very reasons you're seeing here and all the stuff I'm describing. And then that's going to be where your score comes out at the end. So that's somewhat of the why behind what we're doing and how that is developed through this whole redesignation process. So I just didn't know if anybody had any questions, anything you wanted to mention, thoughts, insights, around redesignation itself. All right. Well, we're in a good place as a lead, I believe, for a number of things that I just mentioned a little bit ago, as far as quality things that we've taken action on. You're all great network of providers and very responsive. And even when we've had to work through certain things with certain organizations along the way, it's always ended up in a positive scenario. So we're very grateful we have that in our network and the cohesiveness behind it. We're going to have some work. Our policy, we're going to have to uphold it now more than ever, just based on how some of this redesign has occurred. The biggest message I can give around that is if you're running into any issues with your compliance to the policies and the things that have to occur as far as the administrative burden for health home programming, let us know. Make us part of that discussion so that we can, number one, partner with you on it and come up with some strategies to resolve the circumstance. But secondly, support and advocate for you in the instance there was something that happened to be audited from the outside of the health home. And if we have an awareness, we can better advocate and support you as a provider. So that's the other reason we want to have that transparency, why you're running into certain factors. Okay, so that's redesignation updates that we have thus far. So move on. NetSmart, totally changed gears. That whole reporting server, self-service reporting that we've been talking about for the last year and a half or more, actually now, it got started, it was put on hold. There was a new platform that was coming, and they got to put on ice again. Well, it's actually happening now. Um, I think we had mentioned a couple months back that it was coming down the pike. NetSmart's starting to do some trainings on this new platform, and they're asking that any reports that you're currently utilizing as a CMA, that if it's something that you want to continue, that you make sure that the lead is aware of it. So we have a quick turnaround on that. So we're asking if you have certain reports that you want to look at for consideration for NetSmart to look at, to publish in that server, to let Taylor Dawson know by the 27th, close of business of this month, which would be this Thursday. So please, make sure you include the title of the report in that email. There is going to be a carryover from our understanding between the old and the new platform for a time frame. I don't know how long that is at this moment, but once we know, we will definitely let folks know. I know some providers utilize that report mechanism more than others, so please make sure you reach out if you haven't already. Taylor, did I miss anything on this?
No, you're good, Travis. Thanks.
Okay. Any questions about this particular item for NetSmart? It's one of those hurry up and wait, hurry up and wait, hurry up situations. Okay. Another thing with NetSmart, I had sent out a network last week that there was a hard error happening on the assessments. Um, Still happening. What NetSmart is doing, and I have an example of HML billing questionnaire up here. They're doing a manual update refresh at 12 a.m. daily each day as a workaround so that people can continue to go in and do this assessment work. So it's not fixed. So you still may see this hard error when you go in to try to do something, but just know that by 12 a.m. the following morning, it's going to be refreshed so that should go through and be able to be inputted. Um, so that's their fix at the moment. It's something that they're consciously aware of through their engineering team, and they're looking to fix. So hopefully it's sooner than later. I know we're already up on a week on it, just about. Are people having a lot of issue with this still? I'm just curious if that's kicking up a lot. Nothing. All right. Well, hopefully you're not, because that's one other inconvenience and annoyance if it is happening. Next topic, CFR. I've had this up the last handful of months. Just I want to make sure it's an item on here for a bit more. A number of organizations have started that process, working with the CFR unit um, through Department of Health for OMH. We just completed that process with our internal CMA. As I mentioned last month, as long we were told when we met with that analyst through CFR that was assigned to our organization, as long as an agency's making the effort, because everybody kind of got this information late after the fact, at the end of June when the deadline was in May, so that folks were scrambling. They just want to see an effort at this point and working towards getting it submitted. It's a matter of if an organization is not taking those steps to work with the CFR unit to get that established, that there could be potential ramifications down the road, such as withholding Medicaid claims payment, et cetera. So it can become a real big stickler of an issue if an organization is not taking action on this. So for those supervisors on, if you haven't, please make sure that your finance and administrative team is aware, so that they can start asking questions and take a look at this. and depending on what type of an organization you are, as far as reporting for the CFR, some forms are longer than others. So there's an abbreviated form for reporting for certain agencies if you qualify. So those are all things that will come out in the mix when the agency starts to take the steps to complete this. So that's just a reminder on that. The next reminder, and I had this up a couple months ago, but I wanted to pop it up again because October will be coming before we know it. But any organization through OMH that's especially a mental health organization providing services to actively enrolled members under that program is going to have to complete a patient characteristics survey during the week of October 23rd through 29th. And that has to be submitted during that time frame by a designated survey coordinator with that agency. So there'll have to be one established at your organization. And then there's a FAQ and application link toward the bottom here in the second to last bullet. And then any questions, there will be a link. And I had sent this deck out a few months back. I can resend it if folks would like, just as a refresher if it got lost in the mix. But it would have that active link for folks to be able to click on for future questioning. I'm just going to make a note. I'll send that out with the slide deck just so folks can have that fresh on top of their email. Any questions around this? It's not here yet, obviously, but I just don't want it to get lost in the shuffle as we get closer as summer months end. Okay. Next topic, coalition recalibration. This is all around the budget savings for health homes. The most recent update we got at the end of last week is that CES tool, the continuing eligibility screening tool. Tool that's going to likely take the place of the comp assessment as we get going down the road, and potentially the HML as well. That is still in the throes of being completed. The committee's meeting weekly. The idea is early August to have that complete into DOH leadership. And they want it to have a 10-1 implementation date, obviously, because that's when the budget changes start to take effect. Step down recommendation, there's been no feedback on that from the state. Neither has there been around the community health worker program. And the 1115 waiver, as many of you know, is still pending. So we don't have anything updated specific to health home on that. So not a lot of movement on those recommendations that were put forth from the Health Home Coalition outside of the CES tool. We'll definitely make sure folks are aware once we get more. Lori Lamphere, the exec director for the Health Home Coalition, has been really good about sending things out as she's updated along the way on what's happening through the state, through the coalition, responses from DOH, et cetera. So we'll make sure we follow through with anything that does come through. I just wanted to pause just to see if there's any questions around this. If anybody had anything they want to talk about around the budget or the budget recommendations. Nada. All right. Crickets today again. And that's our listing. We've got People USA and St. Joseph's that are pending still through various stages as potential providers. And we have two other organizations that we're working on currently that are looking to finalize a contract with us, which would start that process. So once that happens for each of those organizations, I'll list them on here as well, but I just didn't want to do that prematurely. But we're excited because they'll add more breadth to our network. So we're excited about that. So more to come when I'm able to mention those organizations. Anything anybody wanted to bring up or talk about? I know we reached out to a number of supervisors on how things were going in some of the areas in our region that got impacted on flooding with all the torrential downpour that occurred throughout this past few weeks. Everybody doing okay? Anything as a lead that we can help with. Just want to put that out there that, if you have someone that is struggling because of those circumstances, to let us know, and we can work with you and your team. And also we can pull in DOH if needed to have discussions on how to support those circumstances. So I just wanted to put that out there for folks. But I didn't know if there's anything that, anybody had that they wanted to bring up or mention as we were on.
Travis, there's a question in the chat from Sarah Arnold about which counties the new agencies that are onboarding are going to be serving.
Yeah, so good question. So both of those organizations one would be Saratoga County specific, with the potential of Warren down the road if everything were to go well. And the other one is for Warren County specifically initially. So they're down on the southern end. Um, we've had some CMAs reach out just about entertaining other, if they're an adult provider, entertaining, what steps it would take to be a children's provider as well, and vice versa. We've had children's provider reach out in regards to what it takes to be an adult provider. So we are having those discussions. We're open to those discussions. There's some red tape that would have to be completed in those instances, but I can just reiterate to this group and to our network that the referrals are out there. We have a list, a waiting list in some counties, Saratoga, Warren, and Washington, and Clinton counties in particular. There's definitely a need that's not going to go away, unfortunately. The more options we can provide, the better we'll be able to serve those folks. So if there are CMAs out there that are looking at their business model and are looking to diversify further, we're always more than welcome to have that discussion to see if that's a potential for your organization. And of course, as I mentioned, there's some red tape, steps that would have to happen if it were to be something that would come to fruition. But just putting that out there for folks. Any other questions? Thanks, Taylor, for pointing that out. All right. Well, I hope folks are enjoying their summer. And if you haven't gotten any time off yet, if you have some coming up, I hope you enjoy and stay safe. And thank you always for everything you do. And we'll talk to you all soon.
Thank you,
Take
Travis.
care, everybody.